First of all, I would like to thank the organizing committee for giving us this opportunity to present our paper in such a prestigious conference. Our randomized crossover trial goes by the title Suhoor Timing in Type 1 Diabetes Patients Fasting Ramadan. Neither me or our team have financial or non-financial disclosures. Just to give you a brief background, that despite the risk of complications, many patients with type 1 diabetes fast during Ramadan. However, the optimal timing of suhoor has not been investigated. We have local studies that have shown that breaking the fast due to hypoglycemia is common during the morning hours. And current guidelines recommend late suhoor. However, this does not provide sufficient time for correction in case of insulin overdosing and can lead to breaking of the fast in the early hours. So, reviewing the literature, we have found this knowledge gap that we can't answer the question, what is the optimal timing of suhoor during Ramadan in type 1 diabetic patients? Our hypothesis that we advocate an approach involving the consumption of suhoor meal 90 to 120 minutes prior to dawn, accompanied by insulin administration. Additionally, a high-protein snack administered without insulin is recommended just before dawn. This methodology is designed to facilitate and extend time frame for pre-dawn blood glucose correction, thereby ensuring optimal levels prior to the commencement of fasting. Simultaneously, the regimen aimed to preserve glycogen stores during the fasting period. In this study, our main objective was to estimate hypoglycemia risk of type 1 diabetic patients fasting during Ramadan when taking suhoor 90 to 120 minutes before dawn, which we refer to as early suhoor with a pre-dawn snack, compared to 30 minutes before dawn, which we will be referring to as late suhoor, as recommended in the DAR guidelines. Secondary outcomes encompass various measured variables: the frequency of breaking the fast, parameters of blood glucose control using the ambulatory glucose profile, and patient preference between the two groups. In regard of the design and settings, this was a randomized parallel two groups open label crossover trial. Participants were randomly assigned in a 1-to-1 ratio to one of the two groups, and the trial was conducted in a single center at King Abdulaziz Medical City National Guard Ministry Health Affairs, Jeddah. Data were collected using pre- and post-Ramadan questionnaires and flash glucose monitoring using a Freestyle Libre device. In regard of the procedure, patients were randomized to an early or late regimen and started a diet plan as soon as the study began. In the second week, patients switched regimens following the crossover design of the study. The patients were instructed to break their fast when their blood sugars was less than 70 mg per deciliter or more than 300 mg per deciliter. Patients accustomed to adjusting their insulin dose based on the results of home glucose monitoring were allowed to do so. Participants that were included were type 1 diabetic patients that were diagnosed more than 6 months, age more than 14 years, committed to performing self-monitoring blood glucose measurements or continuous glucose monitoring, on multiple daily injections or an insulin pump, and previously fasted during Ramadan and planned to fast during the upcoming Ramadan. In regards of the exclusion criteria, patients with cognitive impairment or learning disabilities, renal or hepatic impairment, adrenal insufficiency, pregnancy, alcohol use, and psychiatric disease were all excluded. In regards of the baseline characteristic for the participants, a total of 44 patients with type 1 diabetes were randomized in a crossover design. The mean age of the participants was 25 years old. The majority were females, representing 71%, and 10 patients, representing 23%, reported prior to the study frequent hypoglycemias, more than 3 episodes per week. And except for 2 patients on insulin pumps, all patients were on MDIs, multiple daily dose injection therapy. The mean duration of diabetes was 13 years, and 30% had an A1C at target of less than 7%, and 21% had an A1C of more than 9%. (89% met the high-risk criteria for fasting according to the DAR guidelines prior to inclusion in the study. In regard of baseline characteristic and complications, 86% had no complications, and 11%, representing 5 participants, had evidence of retinopathy, and only 1 patient had an evidence of nephropathy, representing only 2% of the participants. In total, 38 patients completed both randomization phases, and breaking the fast was reported during early Suhoor regimen by 20 participants, representing 65%, and 18 participants in the late Suhoor, representing 58%, with a p-value of 0.16. With a mean number of fast days broken of 2.5 versus 2.05 days, respectively, with a p-value of 0.72. There was 1 episode of severe hypoglycemia reported during the late regimen, and no diabetic ketoacidosis admission were reported during either regimens. Breaking the fast due to hypoglycemia was more frequently reported during the morning and early noon hours than pre-sunset. Morning fast breaking was reported by 10 participants in the early Suhoor regimen and 14 in the late regimen participants. And noon fast breaking was reported by 11 early Suhoor group versus only 5 participants during the late regimen, with a non-significant p-value of 0.087. Hypoglycemic events, as detected by flash glucose monitoring, occurred significantly more frequently during the morning and early hours of fasting than in the evening, with a p-value that was significant of less than 0.001. However, there was no significant difference between the regimens. The mean hypoglycemia events rate per patient per week during the early versus late regimen was 0.83 compared to 0.78 events per patient per week. Analyzing the AJP report data revealed a longer average duration of hypoglycemia while on the late regimen compared with the early regimen, and there was a high prevalence of poor glycemic control. The time above range and the time below range were above target during both regimens, but with no statistically significant difference between the 2 regimens. In regards of the patient satisfaction, the post-Ramadan survey revealed a preference for the late regimen, with the main reason being the convenience of timing. In summary, In the early versus late regimen, self-reported hypoglycemia leading to breaking the fast didn't differ significantly between groups. The average number of days on which fasting was interrupted was similar in both groups. There was a significantly higher prevalence of hypoglycemic events during the early fasting hour, morning and noon, compared to pre-sunset in both regimens. And the post-Ramadan satisfactory survey showed a preference for the late regimen, mainly due to its convenient timing. We conclude that both suhoor regimens exhibited minor variability and were well tolerated. Patients with type 1 diabetes can choose either regimen based on personal preference to minimize complications and in the fasting experience. Further studies are required to explore diverse dietary and insulin dosing regimens for ensuring safe fasting in individuals with type 1 diabetes. You can find our references if you scan this QR code. And now we can conclude, and thank you for your time.